في خلق السماوات والأرض ويتفكرون في خلق السماوات والأرض ربنا ما خلقت هذا باطلا سبحانك ربنا ما خلقت هذا باطلا سبحانك فقنا عذاب النار ربنا إنك من تدخل النار فقد أخزيته وما للظالمين من أنصار ربنا إننا سمعنا مناديا ينادي للإيمان أن آمنوا بربكم فآمنا ربنا فاغفر لنا ذنوبنا وكفر عنا سيئاتنا وتوفنا مع الأبرار صدق الله العظيم.
Sadaqallahu al-Azim. Now I would request you to please stand on your seats for the national anthem. So now we will begin the actual session, and this session is regarding the management of hypoglycemia and type 1 diabetic population. So because of the shortage of time, I will just go straight to the presentation. Let me announce and then call upon the stage the chairpersons for the particular sessions. These are going to be our respected mentor, Professor Dr. A. Chamir. Next is Professor Musarrar Tiaz. And of course, Dr. Atif Munir. Please join us on stage. All of them have got wonderful contribution to the diabetes and endocrinology in Pakistan, if they have a number of distinction under their names. So now briefly regarding the speaker of this session, this is going to be Dr. Ahmed Iqbal. He is, very briefly I will introduce him. He is from UK and currently he is working at the University Hospital at Sheffield. So interestingly, he has got his own research work on this topic, that is hypoglycemia in type 1 diabetic population. So we will love to listen to him this morning. So I will request him to please join us on stage.
So a very good morning. Assalamu alaikum to everyone. It's an absolute pleasure truly to be here today. Lahore is my hometown, so it gives me a true pleasure, and I'm very thankful to the President, and a very good morning to the respected chairs. So I've been asked to talk about hypoglycemia and type 1 diabetes. And what I hope to do over the next 20 minutes or so is talk you through the clinical problem, and then talk about solutions which are currently available to deal with the problem, move on to where the unmet need is and what we need to do next, and finally give you a summary of my thoughts on this topic. And actually, what I'd be very much interested to learn is from you as to the local experience of this problem in Pakistan and what solutions you are using to deal with this complication. So first, the clinical problem. The definition of hypoglycemia was agreed by the International Hypoglycemia Study Group, which I'm a part of, and it came up with 3 levels. Level 1, less than 70 milligrams per deciliter, is an alert value. Level 2 is a clinically relevant hypoglycemia, which needs to be reported by the FDA and the MHRA in clinical trials of anti-diabetes medications. And any episode requiring help from a third party is known as severe hypoglycemia. Now immediately, the pediatric endocrinologists amongst you will recognize that the definition is problematic because children almost invariably will need help for treatment. But this is a definition that's been accepted by consensus, and that's what we're using at the moment. Now, I hardly need to tell this audience that hypoglycemia is an issue in people with diabetes. So in 2035, nearly 500 million people around the world are going to have diabetes. The vast majority type 2, but a good chunk will have type 1. And interestingly, the incidence of type 1 is rising within the Middle East, North Africa, and South Asia region. And on average, a person with type 1 diabetes will have 2 to 3 episodes of symptomatic hypoglycemia per week, and sadly 1 episode per month, which needs help from another person for treatment. And the costs are huge for the person, for society, and actually for the whole healthcare system. But you would say, isn't hypoglycemia less of an issue with technology and all these new things that we have to play with? These are data from the North American INFORM study, which looked at the incidence of real-world hypoglycemia in people in the United States and Canada. And you'll see that actually the incidence of severe episodes is 3.5 per year in those with type 1. And if you look at the proportion of people with type 1 who are afflicted with severe hypos, it's more than half. So even in the most advanced, developed nations in the world, hypoglycemia continues to be an issue in those with type 1. So in order to understand the problem, we need to go back to the physiology. If you don't have type 1 diabetes, the body has a number of layers of defense that protect us from hypoglycemia. And this is because the brain relies almost exclusively on glucose as a fuel. So when the sugar goes to around 83 milligrams per deciliter, insulin is switched off, your first line of defense. If the sugar continues to fall down further, you produce glucagon at around 68 milligrams per deciliter, which is over here. And if it falls further yet, you make adrenaline. Both glucagon and adrenaline cause glycogenolysis and gluconeogenesis. You break down starch and you mobilize new sugars from glycerol and amino acids. But the net result is the same. You increase the amount of plasma glucose. And adrenaline has an added benefit. You see, what adrenaline does is it gives you shaking, trembling, sweating, all the symptoms your patients will tell you that they have with hypo, and that acts as a cue for the person with diabetes to take corrective action and consume carbohydrates. Now, sadly, when you have type 1 diabetes, you immediately lose your first line of defense because you don't have the ability to switch insulin on or off. Your beta cells have been exhausted. And also, most people within 5 years from diagnosis lose glucagon, your second line of defense. And therefore, people are almost exclusively relying on adrenaline, the third line of defense. But yet, with repeated episodes of hypoglycemia, the level at which adrenaline is produced in response to the hypo shifts lower and lower and lower. And this means, sadly, that a good chunk of people end up losing their adrenaline response as well, leading to this clinical syndrome of impaired awareness, where frighteningly the person does not even know that they're low and can have a severe episode. And it affects in 1 in 4 people with long-duration type 1 diabetes, and it's caused by recurrent episodes to hypoglycemia. And actually, the good news is this. If you can avoid hypoglycemia carefully, scrupulously, meticulously, for as little as 2 to 3 weeks, you can get back the awareness in the patient. And this suggests that the problem is not anatomical or structural, it's a functional problem to do with hormone release in response to low glucose values. If left untreated, impaired awareness is associated with a 6-fold higher risk of severe hypoglycemia in type 1 diabetes. Hypoglycemia has huge consequences. It can affect the heart, it can cause sudden cardiac death, it can increase the risk of strokes potentially. And I was reminded yesterday for the wonderful work Dr. Abbas and colleagues are doing here in Pakistan, that actually in addition to seizures, coma, and death, hypoglycemia recurrently, particularly in older people, increases the risk of dementia. My own work over the last 10 years in Sheffield has discovered new mechanisms through which hypoglycemia increases cardiovascular risk. We've shown that hypoglycemia through the adrenaline response makes your blood stickier and clotter, and that makes your risk of heart attacks go up quite significantly. And also we show that hypoglycemia activates the immune system and critical players within the immune system, which increase the risk of heart attacks. We also showed through my work that hypoglycemia itself is bad for the heart. The low glucose environment causes generation of inflammation and variability of glucose from low to high. So I'm sure we all have patients who overtreat an episode of hypo, and that variability, ladies and gentlemen, is also harmful for the heart. All in all, hypoglycemia has been associated with cardiovascular risk in type 1 and indeed in type 2 diabetes. Okay, so I've told you that there's a problem, that despite advances, there continue to be consequences, but how do we address the problem? One answer is develop new insulins. You see, when we have beta cells and they're functioning, insulin is rapidly released into the portal vein. But I always say to my fellows and students, we give insulin in the wrong place and at the wrong time. We give insulin subcutaneously, and often there's a mismatch between the patient consuming the meal and taking the insulin, and this mismatch very commonly leads to hypoglycemia. One answer would be to have rapid-acting insulins that kick in immediately. And of course, there's been a lot of work done over the years in analogs which undoubtedly reduce the risk of hypoglycemia. I was reminded over breakfast, a conversation I was having with a friend and colleague as to the accessibility of insulin and analogs, and of course they're expensive. And they demonstrate a reduction in hypo, but if you can get your patient on it, it could just be the thing which allows them to avoid those severe episodes, as shown in this study from Denmark. My work has also included inhaled insulin. We did this with Minnesota. So if the problem is you're giving insulin in the wrong place, how about you give it rapidly by inhaling it? And this was some work done which showed that actually inhaled insulin can reduce hypoglycemia, but you see the problem we came across is that there are pulmonary issues and you need for spirometry and monitoring, and it never really took off. A promising idea, it was data presented at the AD in Orlando, if some of you were there recently, but again, hasn't really taken off. So what would an ideal insulin look like? Well, it would only really act if the glucose was high, and it would switch off if the glucose was low. Now, this gentleman over here is Steve Morgan, and he's a very rich man, a philanthropist, whose son Hugo, who's in that picture, has type 1 diabetes. So Simon Heller and I, who is my mentor, colleague, and friend, met this chap, and he's donated £50 million to Diabetes UK, and his ask was simple. He wants us, as a group of researchers in the UK, to develop new insulins, smarter insulins, and ideally pursue a cure for type 1 diabetes. And a good chunk of that money is going towards developing these smart insulins. So I'm very hopeful in the next 5 to 10 years, we'll have these compounds become available that can actually switch off and switch on in a glucose-sensitive manner and reduce the risk of hypoglycemia. So that's on insulins. But what about technology? I did the technology workshop yesterday, and I was so heartened to learn from all the fellows the excitement around these gadgets. And they truly have demonstrated benefit in type 1 diabetes, particularly continuous glucose monitoring. This is a study from Holland, where people who had problematic hypoglycemia, so they had impaired awareness, were first given finger prick monitoring, and after a washout period, trialed a continuous glucose monitor. And the investigators looked at the incidence of hypoglycemia in both parts of the study. And you can see from this graph that when these participants used continuous glucose monitoring in orange, there was a reduction in hypoglycemia at all levels. And what was even more striking was the incidence of severe hypoglycemia more than halved. So CGM definitely works in reducing hypos, and it makes sense, right? You know your sugar levels are falling, there's going to be an alarm, and you can take corrective action which will prevent you from falling on the floor and fitting. But what was really interesting is the awareness of these people when it was assessed before and after the trial did not change. So they did not get their warning symptoms back. Closed loop, the so-called artificial pancreas, which we use, is also very effective in reducing hypoglycemia. The principle is a continuous glucose monitoring device sends a signal every 5 minutes to a pump, and the pump then delivers insulin automatically to keep sugar levels on a set desired glucose. When the sugar levels are falling low, the pump simply switches off delivery of insulin to prevent hypoglycemia, and conversely, when the sugars are rising, the pump steps on the gas and gives more insulin. And in this study, it was shown that when you compare this closed loop technology, automated insulin delivery, to a manual pump, which is just a pump not talking to the sensor, there was an actual reduction in the risk of severe hypoglycemia. But again, people did not get their awareness of hypoglycemia back. All in all, when it's all said and done, the bottom line is this. CGM will reduce your time in hypoglycemia below level 1, less than 70 milligrams per deciliter, by around half an hour per day. And in level 2, which is more clinically significant, by around 15 minutes. So you get benefit for sure when you reduce severe hypos, but these are the actual numbers. And that brings me to my third point, and perhaps the one which is closest to my heart. You see, analogs, technology, these are all things which are expensive, but yet what if I told you that there was a solution which was cost-effective and clinically effective and had enormous potential to be deployed in resource-stretched settings? That is diabetes education. We did this work in Sheffield, and we asked the question, what if people were taught the difference between quick-acting and long-acting insulin, the fact that they need to titrate their insulin for exercise, the fact that they need to increase the doses for illness, how would that affect the risk of hypoglycemia? And what we find is that 1 year prior to the intervention, people who had low A1Cs had higher risk of severe hypos, and of course, as the A1C rose, the risk of hypos decreased. And a year after the intervention, the risk of hypoglycemia significantly reduced. And indeed, this work from Sheffield again, for the dose-adjusted studies, we found that when you take these people and you give them a flexible intensive course on insulin education, as I've described, you can significantly reduce the risk of hypoglycemia in all people. And actually, in those who have impaired awareness, you can have, more than halve, the risk of severe hypoglycemia as well. A 5-day course where they come in and talk to educators like dietitians, diabetes specialist nurses, doctors, and they go away and they get these amazing results. So there is definitely a problem. I hope I've convinced you of that. There are solutions with neuroinsulins. We're using technology. It's extremely effective, and education clearly has a part to play. But you would have noticed from all the slides I've shown so far that the impaired awareness syndrome is not necessarily always addressed. And indeed, all the trials of CGM and closed loop have not been able to reverse impaired awareness. This is a group of people that are at the highest risk of severe hypoglycemia in type 1. So around 2 years ago, there was a call put out by the NIH, NIDDK in the US, and the question they asked was this: we will provide the money, the Americans are very rich, and you will come up with the solutions to this problem. And it was open to the rest of the world, which is quite limited for US studies, which are normally for US centers. So Simon Heller and I put in an application from Sheffield, and we were fortunate enough to be granted the money alongside centers in the US like UPenn and University of California, San Diego. And the ask is very simple. We're going to give you around $2.5 million. You as a group, as a consortium, need to come up with solutions to the problem of impaired awareness of hypoglycemia. And what we're studying is people who have, are adults with impaired awareness, they have a clinical diagnosis of type 1, and they've had diabetes for more than 10 years. These are the group of people that are at higher risk of hypoglycemia. So this is our team over here, and I know colleagues know Simon well, who's a real friend and an enthusiast of Pakistan. Myself and some other colleagues in our facility there in Sheffield, where we do our studies. And this is a trial design. So just going to break this down very simply. We're taking people who've never had closed-loop technology, the artificial pancreas. That's one arm. And I'll focus on that first, this one over here. And then people who are already using technology but still continue to have impaired awareness. That's the other trial. It's 2 distinct trials. And we're using clamp methodology. What is a hypoglycemic clamp? You see, when people come in, we need to measure how much adrenaline they're making in response to hypo. So we give them a high fixed dose of insulin, and we also give them glucose intravenously, and in an experimental setting, gradually reduce their glucose to achieve the experimental stimulus. So we'll be measuring what they're making in terms of their adrenaline at baseline, and then randomizing them to technology, either closed loop or education plus CGM, and then reassessing their adrenaline or epinephrine response at 12 months. And then depending on their response, they're going to be re-randomized into other interventions, including HARP-DOC. HARP-DOC is a psychoeducational course. We recognize that some people have very unhelpful behaviors around hypoglycemia. I have a patient of mine who starts to feel the symptoms of hyperglycemia at a sugar level of 10. He says, "I feel terrible, doctor." And he deliberately gives himself insulin to run very low, increasing the risk of hypo. HARP-DOC employs almost a cognitive behavioral therapy approach, a psychiatric approach, to unpick and untangle these unhelpful behaviors. So that's people who've never tried technology. But how about those that continue to have problematic hypoglycemia despite using state-of-the-art technology like closed loop? In this group, what we're going to do is give them a different kind of closed loop, but more importantly, we're going to give them education to see if education can help them extract the most out of the technology. And again, there's a run of second randomizations where we'll look at people who don't respond, whether we can rescue them with HARP-DOC and other psychoeducational interventions. This trial's going to have its first participant, first visit in the UK in January, God willing, inshallah, and the US sites are also getting their IRB, which is their Institutional Review Board, as we speak. So, ladies and gentlemen, more than 100 years have now elapsed since insulin was first used at the University of Toronto. And I hope I've been able to demonstrate to you that iatrogenic hypoglycemia continues to be a major barrier in people living with diabetes. Technology is amazing. It's revolutionized the care of people with hypoglycemia in type 1. but it's expensive, and technology is only as good as the person using it. If your patient does not understand the basics of diabetes and how insulin works, they will not be able to get the most out of it. Technology also does not reverse impaired awareness from all the studies to date. Education is absolutely key. It's cost effective, and when used with technology, can be transformative for your patient. Impaired awareness continues to be a significant issue for the diabetes community, and we are hoping to come up with innovative solutions to try and tackle the problem in due course. With that, I'd like to thank you all very much for listening.
Dr. Ahmed Iqbal, thank you very much for your valuable insights. Being state-of-the-art lecture, we are going not to take any questions. If you have any, then you can meet the speaker. He's around in the hall after this session. So, because in the interest of time, I'm just going straight to the panelists for your, valuable comments.
Okay, thank you so much for such a nice talk. I just had one small comment. We all know these all gadgets and all those things. The place where we are practicing at physicians, we know that most of the time as healthcare physicians, we sometimes focused more on hyperglycemia, managing it, sometimes maybe frightening patients so much that they use insulins more so, leading to hypoglycemia. And secondly, most of our people with type 1 diabetes are still on conventional human insulins. We do not have the luxury of these insulins, newer insulins, which are more physiologic in most of our patients, plus also the luxury of all these CGMs and insulin pumps. So meantime, your take-home message is very clear. Until and unless we have all these things, education is the key to make people understand that not only hyperglycemia, but hypoglycemia is very important. So thank you so much for your clear message. Thank you.
Thank you very much, Ahmed, for an excellent talk and putting the perspective of hypoglycemia. And I think a couple of comments basically. In a country where all the resources are available, you are still having a problem, likes of US and UK. Imagine what will be a situation here, and you asked about the question that how things are happening here. So you can well imagine, one of the reasons is, I'll talk briefly about that as well. But I think the way as you have described, the newer insulin is the answer, which is still a way to go. And then of course technologies, and as just mentioned by my co-chair, that is still not accessible to most of the people. But you mentioned the most important part we tend to forget is the education and the knowledge of our patients. But I'll add a small part to it, that educating a person who is very naive to use of new technologies, to use of newer insulins, and their level of education is even a bigger challenge in this part of the world. So I think it'll be very interesting if we collaborate in one way or the other to see how in this resource constraint, plus people who are not very well educated, and most of them being children, is a real big challenge. So it'll be interesting to collaborate. They say you want to go too far, you want to go far in your research, collaborate with people. So we are here for collaboration, and thank you for excellent talk, Ahmed.
So I'll be brief. Thank you for traveling all the way from UK and your talk, really appreciate. Just a query, and you can answer it in the later session. So with the advancing use of technology and the availability of technology in your part of the world, and the resources for structured education that you have over the years with the increasing use of technology, has your uptake of structured education through Daphne gone up as well in parallel?
Thank you very much. That's a really good question. So our philosophy is this. We always start off with education as a base. So everyone who is going to go onto the technology, we say to them, this is the first step. We need to do Daphne. We'll do the program. And then once you have the skills and knowledge and expertise to self-manage, the second step is we'll move on to CGM. Once you know that and you're good with that, we then move on to the CGM and the pump talking to each other if you so wish. And what I'll tell you, which is interesting, very briefly, is just with the education, many of their issues are resolved. So we're using education as a bedrock, which will allow patients to maximize benefit from technology. Great question. Thank you.
And I would just like to quote two things for with regards to type 1 diabetes, getting into the shoes of the person with type 1 diabetes. So that's kind of stayed with me all along. So I was attending this Diabetes UK patient support group meeting when I was a trainee. This guy who was 55 years old on an insulin pump described hypoglycemia for the audience as like, and I quote, that it's a kind of an Alzheimer's state where you know something is terribly wrong and you don't know what is wrong and what to do about it. And just one last thing, statistically, the divorce rates among parents with children who have type 1 diabetes is much, much higher than divorce rates among parents who do not have children with type 1 diabetes. So that kind of sums this all from the other side. Thank you.
That's wonderful, and I completely agree. Really useful insight. Thank you.
So thank you very much for your valuable comments. With this, we conclude the session. We move on to the next session, and Pakistan Endocrine Society is very grateful to all of you. Thank you.